Hi students, today we'll be doing a demonstration of suctioning a tracheostomy and providing trach care. To begin with, come professionally dressed according to the University of South Alabama's College of Nursing uniform policy. The first step will be to verify the orders and verify the hospital policy. Next, the nurse will gather the equipment needed for the procedure. And verify the expiration dates. Positions the trash can and then performs hand hygiene. If the nurse feels he or she is at risk for exposing themselves to any secretions at this point, they may don clean gloves. If they do not feel at risk, they do not have to don clean gloves at this point. So now you will raise the bed to a working height, identify two patient identifiers, while she's identifying the patient ID, she will also check the patient's armband for any additional allergies and ask the patient if they have any allergies not noted on the armband. Once that's completed, the nurse will explain the purpose of the procedure to the patient and provide patient privacy. Now the nurse dons the PPE. The first thing to place on is the gown. Notice how she's made a thumb hole there. That's going to help her secure the gown and make it easier for her to put the gloves on. Following the gown, the nurse places the mask on. Next, put on your goggles. And now apply clean gloves. Now that the nurse is appropriately dressed, the nurse will assess for signs and symptoms of upper or lower airway obstruction requiring suction. During the respiratory assessment, the nurse is listening for an abnormal respiratory rate, adventitious lung sounds, nasal secretions, gurgling, drooling, restlessness, gastric secretions or vomitus in the mouth, and coughing without clearing their airway or having their adventitious lung sounds improve. Once the respiratory assessment is complete, the nurse will take a set of vital signs and note any symptoms associated with hypoxia or hypercapnia. These signs and symptoms include a decreased pulse oximetry or SpO2 reading, an increased pulse or blood pressure, apprehension, anxiety, lack of concentration, lethargy, decreased level of consciousness, confusion, dizziness, behavioral changes such as restlessness or irritability, an irregular heartbeat, pallor, and cyanosis. Once the pulse oximeter is placed on the patient's hand, leave it intact there throughout the procedure. The nurse is going to place a towel across the patient's chest to keep the gown clean while the suctioning is occurring. Set the suction between 100 and 150 millimeters of mercury, not to exceed 180 milligrams of mercury, and set the oxygen flow to 100%. Open the suction kit using aseptic technique. Okay, we're going to don sterile gloves without contaminating. Pick up the sterile container and open it. Pick up the suction catheter and replace the saline into the sterile kit or onto the bedside table. Now with your non-dominant hand, pick up the suction tubing and attach the suction catheter without contaminating the sterile hand or the sterile catheter. Make sure that is a tight connection. Dip the catheter into saline to lubricate and suction a small amount of saline to ensure the equipment is working properly. Gently apply ambu bag set at 100% FiO2 and slowly hyperoxygenate the patient by administering 5 to 6 breaths over 30 seconds. That wasn't very smooth there, left the pillow. Without applying suction, gently insert the suction catheter into the trach tubing, being careful not to contaminate the catheter by touching the patient gown, your PPE, and not touching the outer cannula with your sterile hand. It's best to time catheter insertion with inspiration. Once resistance is met or the patient coughs, pull the catheter back 1 centimeter or 1/2 inch. Begin applying intermittent suction by placing and releasing the non-dominant thumb over the vent of the catheter. Slowly withdraw the catheter while rotating it back and forth. The catheter should be withdrawn over no more than 15 seconds, and encourage the patient to cough. Monitor the patient's vital signs and oxygen saturation throughout the suctioning process. Stop suctioning if there is a 20 beat per minute change, either an increase or a decrease in the pulse rate, or if the SpO2 or pulse oximetry falls below 90% or a 5% drop from baseline. Rinse the suction catheter and hyperventilate the patient after each suction pass, including the last pass. This procedure may be repeated based on the assessment findings and the presence of secretions. Allow at least 1 full minute between each suction pass. After hyperventilating for the last pass, replace the oxygen therapy, remove the sterile gloves, note the gloves will be removed glove to glove with the suction catheter being caught up inside the glove, and then skin to skin. Now, clean up your mess and complete an additional respiratory assessment. During this respiratory assessment, the nurse is assessing for the same things that she assessed for initially, the indications for suctioning, with hopes that those signs and symptoms have improved. After completing the respiratory assessment, the nurse will prepare to do the tracheostomy care, beginning with opening the tracheostomy kit using aseptic technique. Next, the sterile field is removed from the container and placed on the bedside table. Note, the field has a shiny side and a dull side. The shiny side goes down because it's water protected. Place the sterile field on the bedside table. Now you add the contents from your kit to the sterile field, being mindful of the 1-inch sterile border, and place the container back on the bedside table. Next, remove the inner kit, empty the contents, and place it upright on the table, being careful not to contaminate. Now we will pour saline into all 3 compartments. Be careful not to contaminate the lid or the bottle rim when opening the container. Also note, the saline is being poured not over the sterile field or the sterile drape. And recap the saline. Next, you'll remove the oxygen therapy and remove the inner cannula, as well as the drain sponge beneath the tracheostomy faceplate.
Okay, good. Great. That works.
Be sure to secure the faceplate while removing the inner cannula and the drain sponge. Replace the oxygen therapy. And now remove your clean gloves. Glove to glove and skin to skin. Next, don your sterile gloves without contaminating. Organize your supplies on the sterile field. Use the scrub brush to clean the inner lumen and the outer cannula, being careful not to splatter normal saline onto your sterile field. Also note that the supplies are well within the 1-inch border on the sterile field. Once the inner cannula is adequately cleaned, dip it into the second container of normal saline. Remove the inner cannula from the normal saline and use a 4x4 gauze to dry the outer portion of the cannula. Again, being careful not to splatter on your sterile field. The pipe cleaners are used to dry the inner portion of the trach cannula. Again, note that it is not being held over the top of the sterile field. Once the cannula is cleaned, you will remove the oxygen and replace the inner cannula, being careful not to contaminate the cannula. Begin at 9 o'clock or 3 o'clock. Insert the cannula and rotate the cannula to the 6 o'clock position and secure the locking mechanism. Now, dip the sterile cotton swabs into the third normal saline container and clean the stoma. The stoma is cleaned by working under the faceplate and cleaning in a circular motion from innermost to outermost. While cleaning, observe the skin and the tracheal stoma, under the tracheostomy faceplate, and under the trach ties for any skin breakdown, blistering, erythema, drainage, or any discoloration.
Can you say?
You will also clean the exposed outer cannula surface. Note that once the inner cannula is replaced, the sterile portion of the procedure is completed, and it is okay to come in and out of your sterile field, always using the cleanest portion of your Q-tips or your gauze to clean the remaining portions that need to be cleaned. If the skin is wet, use gauze to pat dry the skin. The next step is going to be to replace the trach ties. Probably the most important thing about the trach ties is to know that you cannot remove the old trach ties until the new trach ties are in place. So you see the nurse has a pair of hemostats that's going to be useful for working the trach tie through the hole on the faceplate of the trach. Once you work the tie through the faceplate, you'll wrap it around the patient's neck, and you'll note that Dr. Swansea has the ties not at the same length. One's longer than the other. And the reason for that is so that when she secures the trach ties with a double knot, she will not be over the carotid artery. And the ties need to be either 1 finger snug or 2 fingers loose with the trach ties tied. Once the new trach ties are secured, the old trach ties can be removed.
I don't have any scissors.
Okay. Now it's time to replace the oxygen therapy and remove the sterile gloves and the towel. And complete an additional respiratory assessment.
Freeze.
After completing the respiratory assessment, perform oral care with a toothbrush or oral swabs and a chlorhexidine rinse.
That's enough of that.
Did she connect the oxygen?
When complete, the patient should be left with the head of the bed elevated at least 30 degrees, side rails raised, and the bed returned to its lowest position.
When am I going to turn off the suction and the...
Now that the patient has been returned to a comfortable position, turn off the suction and turn the oxygen flow back off, being sure that the oxygen flow to the trach collar is on. You are turning off the oxygen to the ambu bag. Now it's time to remove your PPE in the proper order, which is alphabetical. Gloves, goggles, gown, notice how you're only touching the inside of the gown. You don't want to touch the outside of it because there may be secretions from the patient's airway on the gown. And finally, the mask. Once the PPE is removed, perform hand hygiene. And now it's time to do the documentation. And you will document the procedure was completed, the characteristics of the secretions, the patient's response, and the respiratory assessment. You will document the trach care was completed, noting the size of the trach tube, the appearance of the stoma, and the surrounding skin.